Yeah, there's many reasons why it's still the number one killer globally. And I think first, let's start with our understanding of what heart disease is. Heart disease is many things. It's not just one thing. It is atherosclerosis, hypertension, arrhythmias, heart failure, and everybody has a different susceptibility to these things. And these are all slow-moving processes. So when we talk about heart disease, classically, it's blockages of the arteries, atherosclerosis, because that really is what kills people. That's the sudden event that everybody's afraid of. Atherosclerosis is a slow, silent process. It's a slow disease, and it takes decades for it to really manifest. And it doesn't really show up as a symptom until 70% of the disease is present. So you can have 50% of the disease and not know it. And oftentimes you can have 50% of the disease and then have a sudden event where 50% plaque ruptures and that causes a heart attack. But you might just be moving along completely unaware of what's going on and have these risks. The mindset of having a symptom is now when you have heart disease. And that's not the case. Heart disease starts happening decades before, and that's why we've got to start looking for it decades before. If we wait till the symptoms are there, then it's already too late, because that's like imagining you can move a cargo ship when it's empty is very nimble and it can move quickly. That's like when you're young. When it's loaded with luggage, with cargo, as we get older, it takes a lot, it's got a lot of momentum, and it takes a lot of effort to move that. So that's what happens when you have a 70% blockage or more. You've got decades of momentum that won't stop automatically. And just because you might have done some lifestyle changes or started some medication a few years ago, it might not be enough. You might still have a lot more momentum driving it forward. Conceptually, we have to really reconceptualize what we believe as heart disease. We're addressing it too late. We're starting too late, and the damage is already done by that time. That, and then we've relied on single marker belief. We think that cholesterol is the only thing that indicates heart disease. That's a 75-year-old thinking. We know that cholesterol is part of the picture, but it is a very complex problem. It's layered, and thinking that one biomarker is going to determine whether you have a risk or not is really not looking deeply, and it's not taking advantage of what we've learned over those 70 years. Part of the belief, part of the thinking was how we were treating it. If we didn't have any ways to slow down heart disease or atherosclerosis, if we didn't know what the true pathophysiology is, and we just thought it was one thing, and we only had very limited tools, well then the thinking, okay, we don't have much we can do about it, this is what we consider normal. And yes, most people as we age will develop some plaque. The question is, when did it start? What are the processes that develop it? And how can we slow it down? We didn't have ways to do that before. In the current era, we have a multitude of ways to do that as it's happening if we detect early. You have to understand that cardiology, especially in the United States, is mostly a end of spectrum treatment specialty. There are stents, there are surgeries, there are procedures, all of that is done after you've got more than 70% of disease, after you showed up with some sort of a symptom, when it's life-threatening. We are really good at doing that. But there's very little that's looked at the other end of the spectrum where it's slowly developing. And that's where we can really make change. And that's where we have to look, because those are slow moving targets. And we can look at multiple different biomarkers very subtly and see how things are changing along the way and correct them early. So yes, people develop plaque. It's something that a lot of people have. Is it part of normal aging? I would beg to differ. Women are very dependent on their hormonal health. Okay, women have a complex milieu of multiple hormones, and they often go higher. Estradiol, progesterone specifically, you will run higher than men. Estradiol, progesterone, and testosterone all play an interconnected role in vascular health. In men, it's mostly testosterone with some estradiol. In women, because there's fluctuations and because there's such a high amount of that estradiol and progesterone, you have a much greater dependency on that for your vascular health. Estradiol and progesterone do have a different interaction in different sized arteries, and because of that dependence, when your hormones start to decrease in production, when you start to hit your perimenopausal years and then into menopause, you lose the protection and from that estradiol and progesterone. Women have a dependence on that. And so the loss of those hormones create a cascade of metabolic problems and vascular problems that then increase your cardiac risk, to the point that after about 10 years post-menopause, you have the same risk about as age-matched men. When they look at women with hot flashes and having vasomotor symptoms, looking at brain scans, I think they were MRIs, they showed that there were higher incidence of microvascular damage or microvascular insult. That's where the vasomotor symptoms happen. It's not the larger arteries. It's in the smaller microvascular arteries. And when they spasm, they will create lack of blood flow, create inflammation, and what are called microinfarcts, or the appearance of mini strokes. Women with higher symptoms of hot flashes tend to have more of those. A mini stroke is a serious thing. These mini infarcts reduce brain matter, and this is what we see that leads to dementia. So this puts them at a higher risk for that. Having hot flashes and night sweats is not a benign thing. It's something to be taken seriously, and it's not something you should suffer through. You want to treat that, especially if you value your brain health. Because the way heart disease tends to manifest is more diverse. Women have a tendency to get more microvascular disease as well. So that often shows up with different symptoms. And that can be, certainly you'll have chest discomfort, but it can be different types of chest discomfort. So if you think about it, what happens is when you look at a microvascular situation, you're looking at blood flow to larger areas, maybe the entire heart. So it ends up showing up as more vague symptoms sometimes. It could be shortness of breath. It could be a feeling of some types of chest pressure. It could be a fatigue. It will also show up as nausea, because sometimes certain arteries have a higher tendency to be more represented or more involved in women. So the symptomatology is very different. It can be very vague. It could even end up showing up as right-sided symptoms, where classically it's left-sided for men. So anything that involves those areas of the upper part of the chest, and this is why so many women have been misdiagnosed with anxiety, because the symptoms were just not fitting into these classic symptom patterns. This is one of the historic injustices done to women. They've just not been studied and appreciated as different people, different beings that have different symptomatology.
So shortness of breath, chest pressure, fatigue, nausea, right side symptoms when it should be classically left. Yeah. I've also heard indigestion and heartburn, back pain.
Yes. Definitely. Yeah. Indigestion. Yes. Because the artery that can sometimes feed the lower part of the heart is the abdomen, and is right above the abdomen. And that can influence a little bit of nausea. It can influence the diaphragm and stimulate that. We know that aspirin is something that most people have at home. Having an aspirin, and there's some belief that chewing it and swallowing it will increase the absorption, but getting something to thin the blood a little bit is going to help. So a full dose of aspirin, and that's usually about 325 milligrams, that's important for an immediate medication or something like that. Outside of that, there's not too much you're going to have at home that you can do. So then what you want to do is you want to stay calm. You want to make sure that you're not doing anything to increase your heart's work demand. So sometimes, and you also potentially you just want to lay down too. You want to wait for EMS to be there. Definitely don't drive yourself to the hospital, because for many reasons you may lose consciousness, you may become lightheaded. That complicates the situation, especially while driving. As I was mentioning, there's one artery, the right coronary artery, that feeds the lower part of the heart and the underside of the heart. That is very influenced by volume. And so sometimes and that's more often involved in women, sometimes the blood pressure will go down. So staying flat and supine is important so that you maintain blood flow, and then try not to get too excited. Take deep breaths to maintain oxygenation, and then try and keep the heart rate controlled.
The breath work. I can see people's eyes rolling like, oh yeah, breath. How do you control the breath and stay calm when you're having a heart attack?
Yeah.
But I did the breath work training with Oxygen Advantage, and it's just about functional breathing. And what I've noticed over the years is that I try to encourage women to please just practice every day. Just do it every day, even if it's just a minute, because the time that you need it, you will not remember what I just taught you. And there's different techniques and things like that. But I think it's so powerful. The breath can control so many physiological responses, and we have it in our hands. It's free. And I'm just on my high horse now, just like trying to get everyone to learn how to breathe, and especially the techniques that may just save your life.